Hello, everybody. My name is Mike Herman. I'm the OBGYN pharmacist here at UNM Hospital, and today I have the pleasure of discussing medication management of postpartum hemorrhage. For our objectives today, we want to do a brief overview of some of the clinical characteristics and findings of postpartum hemorrhage. We want to list pharmaceutical options for and certain contraindications for management of postpartum hemorrhage in respects to medications. And we also want to review the new SRMC updates for postpartum hemorrhage power plan. So, what is postpartum hemorrhage? So we traditionally define it as a cumulative blood loss of greater than 1,000 mils or signs and symptoms of hypovolemia within 24 hours after delivery. It's very, very common and happens in around about 5% of all deliveries. But postpartum hemorrhage actually contributes to about 11% of all maternal deaths, and it accounts for about 1.7 deaths per 100,000 births. And postpartum hemorrhage requiring blood transfusion is actually the leading cause of severe maternal morbidity in the United States today. So very common and very serious disease. When we talk about the four T's of postpartum hemorrhage, this is kind of a mnemonic that a lot of our obstetricians use. So the first T is going to be uterine tone, or uterine atony, rather, is what constitutes about 80% of all postpartum hemorrhages. This is where the uterus fails to contract after delivery. We also have trauma. This is like birthing trauma, uterine rupture, lacerations. This is about 20% of deliveries, and there can be combinations of both trauma and uterine atony as well. We have retained tissues. Sometimes if a piece or part of the placenta gets left in, that can increase our risk for bleeding. And very, very rare, but thrombin is our last T, or the lack thereof. So we have consumptive intravascular coagulopathies and consumptions of fibrinogen and thrombin that can be contributing to increase in hemorrhage. So let's talk a little bit today about uterotonics. So what are uterotonics? They're medications that are used to induce uterine contractions and tone of the uterus. So break them down into three big sections, which is going to be oxytocin, prostaglandins, including carboprost and misoprostol, and ergo analogs, which is going to be methylorgonavine. Tranexamic acid a lot of times is lumped into this group, but it's actually a fibrinolytic medication, and it has no effect on uterine tone, but is oftentimes helpful for reducing blood loss. Let's talk a little bit about oxytocin. So oxytocin is our first line uterotonic that we're going to use both in prophylaxis and treatment of postpartum hemorrhage. So we're using it in nearly all deliveries. And just going into some of the major warnings and considerations. So high dose oxytocin or oxytocin given to very sensitive patients may actually cause uterine hypertonicity, rupture, and tachysystole. So we want to be very careful that we're using appropriate doses of oxytocin and we're doing appropriate titration as well. Rapid administration of oxytocin can actually cause peripheral vasodilation and hypotension, complicating some of the negative effects that occur during postpartum hemorrhage. And not necessarily clinically significant, but oxytocin opposes and has antidiuretic effects. So this usually leads to hyponatremia that's not clinically significant in many patients. Hyponatremia is not a contraindication to oxytocin. It's just something to be aware of. So for oxytocin is actually one of our high alert medications for ISMP due to very, very many submitted medication errors. So this is one of our very high risk medications that we want to hone in on. And some of the reasons that it's a high alert medication is oxytocin when it's inappropriately used in labor induction in patients who don't meet criteria. If there's a lack of standardization between the dose regimen, if there's confusion around look-alike and sound-alike medications, the use of multiple oxytocin concentrations and preparations increase risk for error. The reliance on manually programmed infusion pumps without automated safeguards that are in place, mixed up with infusion tubing, sometimes tubing that isn't connected to the patient or is connected to the wrong IV site. Mix up with dosing and infusion rates, not using certain doses that are located on the pump library. And then using available oxytocin in direct patient care areas without the appropriate orders and communication among healthcare providers are some of the leading causes of oxytocin-related injuries and medication error events. So what are some things that we can do to prevent our errors occurring around oxytocin? So ISMP recommends several steps to avoid oxytocin errors. We want to align the pump library to avoid misprogramming errors, administer oxytocin only within the orders available on the MAR and power plans. We want to label this bag to differentiate it between other similar medications and making sure we're labeling and tracing lines to avoid mix-up. And then we're employing standard orders, sets, and dose rates, which we're going to talk about a little bit later. We want to engage end users like we're doing now in proper training and usage of oxytocin. Employ barcode scanning to make sure that the right medication is getting to the right patient. We're going to limit or mitigate and reduce verbal orders. And we want to also educate and support our clinical staff and practitioners as best we can. Let's talk a little bit about oxytocin dosing. So if you have a patient rolling in, no IV access, who's experiencing a postpartum hemorrhage, you can go ahead and just give the oxytocin, 10 units intramuscular. Oxytocin works a lot better when it's given through an IV site. So only use this if there's no IV access, you lose IV access, or you're establishing IV access and need to rapidly administer oxytocin. Once IV access is established, we're going to give traditionally oxytocin 10-unit bolus that's administered over 10 minutes. And this is going to be available in our 30 units per 500 ml solution that's located above. And then we're going to give that at the delivery of the fetal anterior shoulder or within 1 minute of delivery. And then after that 10-unit bolus over 10 minutes, we're going to assess uterine tone and follow one of our clinical pathways based on delivery method. Here's our oxytocin algorithm for vaginal delivery. You have the 10-unit bolus over 10 minutes above. And then at that point, you're going to assess for postpartum hemorrhage about 500 ml blood loss or higher or uterine atony. If you do find one of those things, then you're going to increase the rate to 54 units an hour for a maximum of 30 minutes and follow the postpartum hemorrhage management that we're going to also discuss below. After atony is resolved or 30 minutes have passed, then we're going to drop the oxytocin unit rate to 18 units an hour. And then after that, we're going to drop it to 10 units an hour for 4 hours after delivery. For C-section delivery, we are going to start with that initial 10-unit bolus over 10 minutes. And then we're going to flip immediately to the 54 units per hour until the hysterotomy is closed. At that point, we're going to assess for uterine atony. If there is uterine atony or postpartum hemorrhage, we'll be continuing the 54 units per hour for 30 minutes and following our postpartum hemorrhage pathway. If atony has resolved or 30 minutes have passed, then we drop it to the 18 units per hour for 1 hour, and then followed by 10 units an hour for 4 hours. Coming back to the pathway, if the hysterotomy site is closed and there's no further bleeding and uterine atony, then we'll move on to the 18 units an hour following delivery for 1 hour, and then move to 10 units per hour for 4 hours after the delivery. So, and then this is a little bit for reference, but this is what, when you open the postpartum hemorrhage power plan and the power order set and the algorithm, these kind of algorithms will help guide clinicians through some of our major pathways. This is pathway for stage 0. During the stage 0, we're assessing for ongoing bleeding, quantitative blood loss, and uterine atony as we kind of move down the protocol to stage 1. This is after there's been a significant blood loss, but not quite postpartum hemorrhage, assessing the QBL, placing that second IV line, and then starting the second line uterotonics. At stage 2 hemorrhage, which is going to be once we've meet diagnostic criteria of hemorrhage, then we're going to activate our OB stat team, and then we're going to potentially initiate a massive transfusion protocol, Quantra, and move towards our second uterine tonic. And then third stage, stage 3, which is our major hemorrhage, GIC, unstable vitals, is when we institute a significant increase in acuity for care. Let's talk a little bit about a utotonic therapy. So carboprost, in addition to oxytocin that we've already given, is one of our favorite uterotonics. This is a synthetic prostaglandin, 15-metha-prostaglandin F2 alpha. It's given as 250 milligram doses intramuscular, and this one can actually be repeated every 15 minutes. Our protocol lists for giving up to 3 doses, but in the literature, we can give up to 2 milligrams. Carboprost is one of the medications that has to be refrigerated, and it's a little bit expensive. It's about $400 a vial. It can stay out of the fridge for probably about 72 hours before it has to be wasted, just making sure to avoid temperature excursions. Carboprost may cause diarrhea. We usually say it does cause diarrhea. And a lot of times we'll actually administer loperamide at the exact same time as we administer carboprost to prevent that diarrhea that is probably coming. One of the major contraindications to carboprost would be active asthma. Carboprost is known to cause bronchospasms, sometimes very, very serious and fatal. So we want to avoid giving carboprost to patients with active asthma. Those are going to be patients that are actively using an inhaler or are having a maintenance inhaler or have been hospitalized for asthma, like remote history of asthma or childhood asthma, that can probably safely receive carboprost. Our next uterotonic is going to be misoprostol. This is going to be our Prostin E1. So this one is not as commonly used now that carboprost is available, but the treatment dose is 800 micrograms buccal or sublingually. And we recommend that over rectal. administration just due faster onset of actions. We're really mostly only using misoprostol if there's other contraindications to other uterotonic agents. But there's really not any major contraindications to misoprostol when used in this indication. Methorgonovine or methergin is our synthetic ergo analog serotonergic agent and is actually very, very nice for postpartum hemorrhage because it has contraction of the smooth muscles of the uterus as well as the smooth muscles of the vasculature. Treatment dose is zero point 0.2 milligrams IM just one time, and then this one's spaced out a little bit longer, so we're repeating it every 2 hours. This is another medication that has to be refrigerated, but it's not as expensive as carboprost. The contraindications, methergin is very nice because it increases blood pressure, but we should really avoid using it in patients that have hypertension, preeclampsia, and cardiac disease. And it's very important that we're only administering both carboprost and methergin intramuscular only to avoid side effects. Tranexamic acid is going to be our antifibrinolytic agent. This is going to help us reduce blood loss in trauma and postpartum hemorrhage. Here at UNM Hospital, we actually use it for prophylaxis prior to C-section. We give 1 gram over 10 minutes, hopefully finishing at least 5 minutes before the C-section. And then for treatment, within our algorithm, we'll give 1 gram over 10 minutes. And we can actually repeat this up to 1 time, but it's very important that tranexamic acid is given within 3 hours of hemorrhage, otherwise it's not effective. It's nice, it's inexpensive, and it doesn't require refrigeration. And the contraindications are mostly history of prior venous thromboembolism or high-risk thrombophilia. So let's take a little bit look at our new power plan that we are putting out into practice. The power plan will be under OB postpartum hemorrhage, and it lists every medication that you could possibly need for postpartum hemorrhage management. There's also these little handy links above, right here, and then right here. Top slide will take us to the OB postpartum hemorrhage protocol, and then the bottom will take you to the oxytocin protocol as well, so for reference. And then looking inside the Pyxis, this is kind of what a screenshot of the postpartum hemorrhage medications that we will have available. So once that order sets placed, all these medications will be available for pulling either in anticipation or on diagnosis of postpartum hemorrhage. So in conclusion, postpartum hemorrhage is characterized by blood loss greater than 1,000 mils and occurs in about 5% of deliveries as caused by uterine atony, birth trauma, retained tissue, and thrombin conception, or our 4Ts. Safe use of uterotonics, including oxytocin per protocol, carboprost, methorgonovine, and tranexamic acid, are recommended for the treatment of postpartum hemorrhage. And SRMC has an active power plan for postpartum hemorrhage. Using our hospital protocols and standardized order sets will help us mitigate medication errors. Here are my references, and my name is Mike Herman. I'm the OBGYN pharmacist at UNM Hospital. I have my email down here. Please reach out via email or in Tiger text if there's anything I can help out with, and I hope you have a great day.